So, obviously I drew the short straw and was asked by John to summarise biomechanics. It's not the first time I've done this, and I do apologise for anyone who's been to any of my talks before, but this one's a little bit different because it's got the S word in it to keep it simple, so there's no physics, there's no maths, there's no vector resolution diagrams, you'll be pleased to know. We can do that later if you want to do that, but this is a bit of a whiz around the pelvis, just to remind you about anatomy, because if you don't understand the anatomy of the pelvic girdle, you're probably not going to understand why this area is so difficult to assess. It's inaccessible. It's often likened, or I liken it to assessing the intertarsal joints, you know, the Lisfranc's area, how difficult they are. So the other thing to say is that if you don't have an understanding of biomechanics, forces basically that are acting within the joint and outside the joint, you can't really begin to start to address somebody's problem. So although I'm going to focus on the actual sacroiliac joint, symphysis pubis, there will be reference to the hip and whatever other things there is there. Most people know that my background is through international running, and when I was in London studying osteopathic medicine, I came across this quote, which was actually at UCH. It's actually out of context. It basically is about two things that we deal with in our lives. We have to deal with athletes' pain, and we have to deal with athletes' pleasure. And I quite like this, saying that nature and mankind has placed us under the guidance of two sovereign masters. It's nice dealing with the pleasurable sides of it, but we all have to deal with the pain. And it's for those two things alone to dictate what we ought to do, as well as to determine what we will do, because if you're in pain, particularly with your pelvic girdle, you're going to struggle. So biomechanics, the study of the action of external and internal forces on the body, especially the skeletal system. We'll look a bit about anatomy, and we'll look at functional anatomy and understand how that relates to functional biomechanics, and then a little bit about the overall movement patterns of the lumbar-pelvic-hip complex. So a little bit on SIJs, innominate, symphysis pubis, myofascial slings. I'm not talking about pelvic organs, and I'm not talking a great deal at all about lumbar spine. That's not today. It's basically, for anyone who doesn't believe that it moves, go to the dissection room. I've got a picture here which is taken from Diane Lee's book. If anybody's really interested in learning pelvic biomechanics, there's two real authors you've got to follow. One is Vleeming and Schneiders from Rotterdam, and the other one is Diane Lee, and Diane Lee is now probably in about her 10th edition. And there's a picture coming up next showing that if you look on the sacral side, you'll see the hyaline cartilage, and if you look on the ilial side, you'll see the fibrocartilage. It's designed, as you can see here, to secure the sacrum between the ilia. You've got an irregular articular surfaces with bumps and depressions. Your sacrum essentially is concave, front to back, and your ilia is convex, generally speaking. It resists large loads, and its shape is adapted to its functional tasks. It's quite good in compression, like all joints that are relatively fat, but the thing that it's vulnerable to is rotation and shear. We'll look in the next diagram, and you'll see how the shape of the sacroiliac joint changes as you go from superior to inferior. This is just a diagram for anyone who's really interested. From top left to bottom right, it's just going through a different period of aging from I think a fetus at 37 weeks to a 17-year-old. And on each diagram, the picture on the right is the sacrum, and the one on the left is the ilium, for anyone who's really interested. So, unlike when I did postgraduate exams, I was asked in a postgraduate exam, why are you bothering to examine in the SI, lad? It doesn't move. This was from an orthopedic surgeon. Just to illustrate what I'm referring to, if anyone here does fluoroscopy, you'll see that when you often inject the joint, you'll see this sort of sinuous curve, and it's formed because of how the joint itself curves like a propeller blade from superior to inferior, and that's where we've got the dark lines and the hatched lines on the diagram on the right on a posterior view. And the sacroiliac joint is remarkably small. For anyone who injects, you can probably get about 2 mils in the joint. And you're actually dealing with quite a small surface area, what they call auricular, which means ear-like. And the positive there means we've got a raise on it, we've got a slight raise, and the negative denotes a depression. So we've got this ability to link together on either side, and it's wedged in. If you look at the top of that diagram, you'll see that in transverse section, the upper levels, the sacrum is wider posteriorly. So if you look at the posterior aspect where you've got your PSIS either side of your spinous process, you can see that the distance from left to right is actually wider. So on the posterior aspect of your sacrum, it's actually wider. But what happens by the time you get down to, I don't know how they get S2.5, it becomes wider anteriorly. So you've got this sort of double wedging effect from top to bottom and side to side. And this is what helps to log it in. And these are some of the sort of more subtle features of sacral anatomy, which unless you really look at these things, this has come from Bogduck's book on clinical anatomy of the lumbar spine and pelvis. You wouldn't really understand how it works. Just a little bit more detail in transverse section. Simon and John are going to talk a little bit more about assessment and injection. One of the things that also plays a big role here in stability and control, apart from joint congruence, is ligaments, and the ones that we particularly get involved in is the interosseous and the posterior sacroiliac, which is shown there. Just a few more ligaments from the front. I wouldn't necessarily draw a distinction about all those iliolumbar ligaments, but certainly if I'm injecting the iliolumbar ligament, I'm going down onto the transverse processes at T5, T4, and then I'm coming back in to the medial aspect of the adjacent ilia. And it's certainly a very big ligament and certainly a very, very big pain generator, and something that comes up in the literature, along with the other one at the bottom, for anyone who's interested, the sacrotuberous ligament, which goes down onto the ischial process because it merges with the biceps femoris. As we've got down there at the bottom, that's a posterior view, PSIS, and then whoever's done this diagram has split it up into lateral band, medial band. I'm not quite sure what TT is, I couldn't find it, but ischium, medial band, lateral band, and PSIS. Your most important landmark when you're assessing from the back is the PSIS. Moving on a little bit, at the front, this is something I get asked to deal with probably every day of the week. I see a lot of rugby players, particularly rugby league based in Leeds, and I get asked to do pubic cleft injections most days of the week. And being able to assess this area, my anatomy at working with Ernest Childers, I don't know if anyone's listened to Ernest Childers in the last 2 years, but he started to break down the anatomy quite elegantly into knowing that, you know, there are certain things that you need to understand about the continuum of anatomical structures from your adductor longus up into the aponeurosis in the rectus femoris. And if you get a chance to read his articles, I'd strongly recommend it. Symphysis pubis, is very, very little studies done on it, probably only one. The movements are from superior to inferior, sort of a translatory movements, usually in single leg stance. Everyone talks about doing stalk views, flamingo test. I can't remember the last time I requested an x-ray standing on one leg. It's a clinical diagnosis and an MRI diagnosis. Serves as an axis of rotation, alternating anterior and posterior rotation. We're going to elaborate on this a little bit more. There's only one study that I've come across, and if you look at the key things, if you look at the bottom, less than 2 millimeters in vertical translation and less than 3 degrees in rotation around a coronal axis. I've seen lots of x-rays over the years where certainly people have got a lot more than 2 degrees of vertical translation, particularly in obviously pathological subjects, particularly when they've had trauma or in hypermobile individuals. The hip, since we've talked about the hip is something which gets a lot more attention, as does the lumbar spine, and I think that the only thing I'm going to say is that you need to know your anatomy about what's happening to ligaments front and back. That's why I put this on. I think the most important bit is that slide. Most people, if you don't understand what degrees of freedom are, you need to go away and look at it, but basically if you've got 3 axes like that mutual at right angles, you can effectively have 2 degrees of freedom at every end of every axis. And the hip is a complex joint, and I'm seeing more and more patients in whom it's very difficult to disentangle, is this a primary hip problem? Is it a hip problem with a symphysis pubis, or is it a patient with a lumbar spine or sacroiliac? And putting all that together is probably one of the most challenging clinical scenarios I see. And if you look at the anatomy of the hip here, this shows you quite clearly where the lines of stress are. There's a line coming down from the sacroiliac joint where you can see that little auricular pattern, that hatched line on the bottom of that big arrow where it says body weight coming down, that compressive load, and your ground reaction forces coming up through your hamstring and through your hip. So what you need to look at is the trabeculae, the lines of stress which are laid down in bone. Myofascial slings, we've gone through bones, we've gone through ligaments. On the anatomy side, this was something that was first really documented again by Vleeming and Schneiders, who talked about the superficial myofascial slings. You can talk about lots of slings deep down, but the ones you need to be aware of are the posterior one on the left, and the one that's received most attention is the one on the left, which is the latissimus dorsi, through the thoracolumbar fascia into the gluteus maximus, and then on the front, on the anterior abdominal wall, across into your adductors. If you really want to know, there was a posterior oblique sling, which we've talked about, the lat dorsi and the glute max via the thoracolumbar fascia. We've talked about the anterior, and then you've got your longitudinal, which, believe it or not, comes from your peronei. I do apologise, there's a spelling mistake there. Biceps femoris and sacrotuberous ligament, and then right up into your erector spinae, and then laterally, the glute med and glute max, the TFL. These are quite big things, and I know that a lot of physios work through trying to strengthen these myofascial slings, which we'll talk about in a minute. So just knowing your anatomy about joints, ligaments and bones. Initial model was by Vleeming, which attempted to explain how all these muscles worked in groups, so they're working synergistically. And that's probably about my only reference to vectors in this talk, so I'm trying to keep it simple. But basically what you've got is you've got a series of muscles, tendons, fascia, ligaments, capsules, bones, acting remotely and in series. And if you really want to look a little bit more, you have to look at Stuart McGill and Brown's work from 2009. A little bit what like people talk about anatomy trains, and I think this is probably the easiest way of thinking about it, because you can't look at any one muscle and say, do we have a prime mover here like you would in lots of other peripheral joints. You just cannot do that with the sacroiliac joint. I'll just mention this model, which came out in '97, because it was a model which sort of came and went, but you'll still hear about it. And it's referred to in Diane Lee's book, this whole thing of tensegrity, which apparently is a sort of a collapse, if you like, a bringing together of the two words tension and integrity. And basically, the theory is that in the pelvic girdle, you have a system which is in dynamic sort of flux between tension and compression, and that's all that's happening. And I've tried to work with that model and looked at that model, and I think it makes sense to think that if you've got a weakness on one side, it could relate to another side. But the whole tensegrity model has never really been studied any further. That's just an outline of the myofascial slings. You'll see that diagram in lots of textbooks to do with form closure and force closure, which we're going to elaborate on in a minute. The whole concept of form closure and force closure was introduced again by Vleeming and Schneiders, and it was taken from the world of engineering to describe two systems that have to work in harmony. So you have to have approximation of joint and congruency of joints with the ligaments at that point. That's the word form. And then you have to have the correct muscles and fascia associated with that, crossing over that. And we have to have those two things in balance. And this diagram is there to illustrate a lot to do with where the slings are, but also rehab. And you'll see a reference at the bottom to how muscles are worked diagonally in torsion and also in flexion rather than extension. So what does it do, this thing? I'm going to give you at least 2 or 3 different definitions, because it depends where you read and how up to date the references are, but you'll see lots and lots of things. This is Richard Dontini. It's a mouthful. I think the 2 words we take from it is that it's a force couple. Basically, you've got forces operating in opposite directions, in parallel, and those force couples end up with a moment which is generated by those forces. It's a mouthful. I prefer to talk about stress-relieving joints. So this is designed to be a sacroiliac joint. You've got a force on the top left, you've got a force on the extreme right, and if those forces are in balance, you'll generate an axis and you'll generate movement. And it's a simple way of thinking that if you've got forces coming high up from above and forces from below, you'll be able to generate movement through an axis somewhere, in the case of the sacroiliac joint, passing between your hips and the symphysis pubis, as you'll see in a minute. So it's generating a force couple, and it's all about balancing force couples, is the SIJ. But what's interesting is how things have evolved in terms of the different research looking at what we feel the SI joint does when it moves. There is a capacity for rotation and translation. We've already talked about that. There are various studies looking at where the axes of rotation might be. This varies considerably between individuals and in the sexes. I liked that definition of the SIJ function of a sort of a shock-absorbing joint. That's one that I used to work with. But another one is that it's got this sort of role to absorb loads longitudinally and side to side, and that's probably how I see the sacroiliac. I'm always looking at what's happening at L5S1 coming down from above and what's coming in sideways to compress the pelvis. Bearing in mind as well that your sacrum constitutes the posterior pelvic wall where your piriformis comes in, wedged between the ilia, and it enables force transmission from one end, the top end, your vertical column, whether you're throwing something, whether you're lifting something, or whether you are planting to walk, to run, to push off. Stress-relieving joint, shock-absorbing joint, to me, sums it up. Analysis of axis of motion, magnitude and direction, location of axis. This has challenged people for many years. And the first people really to talk about this, not surprisingly, because when I worked in hospital medicine full time, I used to get a lot of referral from the obs and gynae department, either after childbirth or after hysterectomy. And we've done everything, doc, so what are we going to do? And these patients had usually got, I'm not quite sure what was going on after a hysterectomy. I don't know whether it would be after they'd been in the lithotomy position. They'd never had back pain prior to their hysterectomy, whether it was because they'd had a transvaginal or a phalansteal incision. We didn't know. Probably accepted that it does move, but that we don't know by how much exactly. We can show you some studies, and the axis remain open to discussion. The problems occur because when you try and isolate a sacroiliac joint with all these different ways of examining it, and I'll show you a few, it's a little bit unrealistic because in effect what people are trying to do is they're trying to clamp it, they're trying to isolate it, and that's not realistic. Because as well as having small anatomical movements, you have this phenomena called physiological movements, which is where the ilia actually rotate as one and sort of pivot around the joint. 3D movements particularly, they don't account for the use of things like rods and wires planted into people's sacrum or ilium. If you put rods in also, they deform, they move, they displace as your muscles and your skin and your fascia move. So it's not that realistic. This other one, this stereophotogrammatic analysis, that was the gold standard at one stage, where it's a computerized system for basically locating radiographically where particular landmarks are, and they used to, and what they do is they implant spheres basically in the opposing joint margins. And two studies have shown that if you look at the bottom here, you probably got no more than an average of 2.5 degrees of range, and probably no more than, that's the rotational movement, and no more than 0.5 to 1.6 centimetre translation. And these are still quoted in up-to-date papers and books, and particularly this one where they use Kirshner wires and the stereophotogrammetric model where they're implanting beads as well. And again, they looked at the amplitude, and this was in 1995, a little bit later, and they came up with a similar sort of figure, rotation about 1.8 degrees, coupled with 0.9 mm of translation. And the interesting thing was that if you had more than 6 degrees of rotation and 2 mils of translation, it was probably pathological. That's never something I've personally measured because I'm not doing the research. Looking at axes, This is probably of more interest because trying to pinpoint where the axis is of rotation is quite difficult. This was a French study calculating the what we call the IAR, the instantaneous axis of rotation, which is something that shifts. Both axes are found to pass obliquely across the pelvis, and I'll just show you a little picture. This is Lavignol's original diagram, and you can see it's going from mid-ilium across to the symphysis pubis down towards the ischium, and then the other side a little bit higher up down towards the middle of the foramen. So just a shot to give us a little bit more of a practical slant on it. What happens when we actually do weight bearing the pelvis? One thing I consistently see from our podiatrist that I do a clinic with once a week on biomechanics is that he talks a lot about clockwise and anti-clockwise rotations, and it took me a while to understand what he was talking about. Well, this is what he's talking about. This is a diagram looking down on somebody's pelvis. And you can see the right leg's in swing phase and the left leg's in stance phase. And the pelvis, the innominate on the right, is rotating counterclockwise, and then when the opposite leg comes forward, it goes the other way. And he talks about a clockwise rotation and an anti-clockwise rotation. And I eventually got round to asking him, and he said, when he makes his diagnoses in the pelvis, this is a podiatrist, he looks at what's happening to the innominate and is it symmetrical from front to back. And he believes that people have clockwise and anti-clockwise. And I think that's a good way to work out what's actually happening in people when they do hit the ground. That you've got either a clockwise rotation if you've got swing phase on the right and stance phase on the left, and vice versa when it comes the other way. But you've got to imagine that you're looking down onto the pelvis. This is what's actually happening from behind. So on the right leg here, the right leg is in swing phase, the left leg is in stance phase, so as the right leg is swinging back, the right innominate is posterior and the left innominate is anterior. So the pelvic girdle is undergoing, the pelvic girdle is undergoing this sort of phenomena. It's going from side to side. It's like a torsional twisting movement, and that, I think, is probably the easiest way to understand it. If you really want to talk about what's happening in the sacrum, for completeness sake, there's actually a forward tilt, a little bit of nutation, a little bit of rotation, a little bit of side bend, and you can see that axis that we referred to before that's coming out towards the ilium and back down towards the greater foramen. We're going to pass that because we've done that. People always get a bit hung up about nutation and counter-nutation. It is important because it keeps coming up when you look at studies looking how much the pelvis tilt, how much the sacrum nods forwards. That's the anterior movement where the front goes forward and the back goes. Strictly speaking, it's a terminology which should be used only for sacral movement relative to the innominate, regardless of how the pelvic girdle is moving, so physiological movements. But generally in health, the sacrum is counter-nutated only when you're laying down, and it moves into slight nutation when you're sitting or standing. In other words, top left there, sacrum's going forward, so the top end of the ear is going forward and the bottom's going backwards, and the opposite is true for a counter nutation. But people seem to want to be able to examine in close detail whether the sacrum is nutated or counter nutated. That's just showing you what's happening there. We've talked about the form closure and force closure thing. I'm going to push on here. We've talked about the mechanical engineering concepts and how important it is to have both form closure and force closure. That's a nice model explaining what's happening there. We've got on the left, you've got the form closure with the sacroiliacs around the ilia around the sacrum. And on the right, you've got all the myofascial components coming in, and the two have to work in harmony. That links in very nicely with that model, which was a model by Punjabi, which basically said that in any spinal system or any articular system, you'd have to have a passive system, an active system, and then neural control from your brain. Physiological movements very quickly, and more recently people have started to talk about what's actually happening around the pelvis, and this other study showed that even in painful and non-painful subjects, they found that getting the patient to stand on one leg like this, and this diagram on the right shows that even when you get a painful and a non-painful patient to stand on one leg, both innominates are actually posteriorly rotated. So you're actually getting a little bit of posterior shift. The one on the The one on the left is the non-weight-bearing side. The one on the right is the weight-bearing side. And if you look at those two diagrams, there's not a huge amount of difference. So we've got a fixed innominate, and then you've got a hatched line to show you the movement. And the bottom line was that in weight-bearing, on the weight-bearing side, the innominate goes backwards relative to the sacrum. That's the close pack position where we can transfer loads. And then on the non-weight-bearing leg, it also goes posteriorly. If we moved on here, I want to just show you some simple rule. This is the last slide. It is thought that, and this is a quote from Diane Lee, it is thought that, and these are the most recent summaries, physiological movements are that sacral nutation occurs during tests that increase load through the pelvic girdle. The pelvis has got to be close packed, and we've got to have both good form closure and force closure. Intrapelvic torsion, which is this sort of twisting movement that you get when you stand, when you can obviously feel the ilia moving from side to side. That's actually a physiological movement with not as much movement of the joint. Occurs during gait or when we have tasks that induce transverse plane movement. So people who are going through twisting, cutting and pivoting. And the bottom line here is that counter nutation, so they're coming back, relative to the innominate, as well as anterior nutation of the innominate sacrum, should not occur during any task that increase the load. So if you have a patient who you suspect is counter nutated, it's probably pathological if they're doing heavy loads. Thank you.